changes in the ALK treatment landscape. Over to Dr. Kaushal Patel.
Thank you. Good evening to all. Hope you can see my slides.
Yeah, your slides are visible. Yeah, and audible.
Yeah. So after the EGFR, we will move ahead with the ALK positive non-small cell lung cancers, and we are discussing the unmet needs in patients having ALK positivity. If we see the global data, then we can say that the lung cancer is the second most common cancers among all cancers in 2020. And it is one of the leading cause of the cancer-related death among all cancers in 2020. Now we see non-small cell lung cancer is consist of approximately 80 to 85% of the all lung cancers. And if we move further ahead, then 5-year survival rate is approximately 25% in localized malignancy, and it is only 7 to 8% into the advanced or distal metastatic cancer. If we dissecting the lung malignancy, then we can dissect it in two parts: non-small cell lung and small cell, and further that is adenomas, large, and other types. And if nowadays in 2022 we have the molecular markers which will further divide the lung malignancy in lots of molecular targeted difference. And ALK is one of them. The ALK gene rearrangement lung malignancy has been documented approximately 1.6 to the 11% of all non-small cell lung malignancy. And if we elaborate the data of the Indian populations, then it is approximately 8% of the non-small cell lung cancer consists with ALK positivity. So if we see, it is typically found into the adenocarcinoma, it is common into the younger populations, it is common into the never smoker or less smoker. And along with EGFR, it is a mutually exclusive mutations. If we see the EML4 ALK fusion or rearrangement gene, that is a type of the gene rearrangement which called as an inversion that occur when the chromosome is broken into the two places and result into the piece of the DNA that is reversed and reinserted into the chromosomes. So the ALK EML4 fusion was initially reported into the 2007. Later on 2012, the crizotinib was first generation ALK inhibitor has been approved. In 2015, we have second generation ALK inhibitor, that is a ceritinib, alectinib, and brigatinib. In 2017, the second generation ALK inhibitors has been approved to be used in a first line, that is alectinib and ceritinib. And in 2019, we have third generation or second line TKI, that is a lolatinib. And in 2021, lolatinib has been approved as a first line treatment into the ALK positive tumors. So already we discussed that the ALK positive non-small cell lung malignancy, they are common into the younger populations, and it is also common into the good subset of the population. They are the non-smoker and very light smoker. The CNS metastasis, they are occurring 20 to 40% of the untreated ALK positivity, and there is a significant challenge associated with the poor outcome. The emergence of the resistant mechanism, including the ALK resistance and CNS metastasis due to inadequate penetration of some of the ALK inhibitors, they continue to be treatment challenge even into the availability of the lots of ALK inhibitors in today's era. So there is a need of additional ALK TKI that will help into the prevent the resistance to the ALK inhibitors as well as improve into the CNS survival or CNS penetrations. So now we have lolatinib, that is a third generation ALK TKI. It's a selective ATP competitive, highly potent ALK inhibitors. They have excellent brain penetration, approximately 75% concordance with the blood. And lolatinib has potential to improve the clinical outcome with overall and intracranial activity into the patient previously untreated ALK positive advanced non-small cell lung cancer. So here, it addressed the unmet needs into the ALK positive non-small cell lung cancer in 2022. It helped into the metastatic brain disease and it prevent the acquired resistance to the ALK TKI. So if we see the crizotinib and lolatinib, then it has highly effective CNS penetrations and bind very strongly with the ALK, and it will overcome most of the ALK resistant mutations. So it has been approved in 2021 as a first line treatments into the patient who having a ALK positive. And we have CROWN study that compares stage 3, stage 4, stage 3B, stage 4 ALK positive lung malignancy who has asymptomatic or symptomatic treated or untreated CNS metastasis has been randomized with lorlatinib versus crizotinib. And if we see the primary endpoint, that is a PFS, and secondary endpoint, they are the overall response rate, overall survival rate, safety profile, and quality of life. Approximately 300 patients has been included in this study. And if we see this patient subpopulation who has been included in study, then if we see the lorlatinib as well as crizotinib, the both group of the populations are almost same, which include the stage of the disease, smoking status of the populations, and involvements of the brain. If we see the result of this study, the primary endpoint, that is a PFS, and if we see the PFS, that is significantly better into the patient who has been treated with the lorlatinib compared to the patient who has been treated with the crizotinib. At the end of the 12 month, approximately 80% of the population, they are disease free compared to the only 40%. So approximately double populations, they have PFS at the end of the 12 month. And if we move further ahead, then the curve is separated wide apart with hazard ratio is 0.28. And if we compare the PFS by the investigator, the same thing has been correct, 80% versus 35% 12-month PFS rate. And the curve is widely separated between two group of the two group of study design. If we analysis the PFS according to the subgroup, then all the populations with ALK positive metastatic lung malignancy got advantage with the lorlatinib compared to the crizotinib, which include the patients having a high smoker, non-smoker, adenocarcinoma, as well as CNS involvements. And if we see the overall response, the calculations, then we can say that it is much better into the patient who has been treated with the lorlatinib compared to the patient who has been treated with the crizotinib. And same, the median time to the response is approximately same into the both group of the study. And if we see the intracranial overall response rate into the patient who have brain metastasis with ALK positive, then we can say that in either of the group, either the patient having a baseline brain metastatic or develop the brain metastasis while on the treatments, the patient will get maximum advantage with the lorlatinib compared to the crizotinib. So the intracranial response is much better into the patient who has been treated with lorlatinib compared to the crizotinib. And this is the curve we can see. There is a huge difference of curve separation. So the intracranial disease is much better controlled with the lorlatinib compared to the crizotinib. And if we see the overall survival, it is also better compared to the crizotinib, with HR is approximately 0.72. If we see the safety profile, then last two column, the adverse drug reactions which lead to the permanent discontinuation of the treatments and adverse drug reactions which lead to the interruption of the dosage, they are almost same into the both group of the study. Either it is a lorlatinib or crizotinib. But if we compare the adverse reaction profile, then it is much easily tolerable by the lorlatinib, that include the alteration into the lipid profile, edema, increase into the weight, and peripheral neuropathy. And if we see the quality of life index in both group of the study, then lorlatinib having a significant better into the quality of life compared to the crizotinib. So efficacy as well as safety better than lorlatinib. So I conclude my talk. The lorlatinib has resulted in significant longer PFS, significant higher overall survival rate, higher overall response rate, higher intracranial overall response rate, and improve into the quality of life compared to the crizotinib in a first-line treatment near ALK positive non-small cell lung advanced malignancy. The lorlatinib intracranial response rate is approximately 82% into the patient with measurable brain metastasis, with a complete response rate of 71% and significant longer time to the intracranial progression. The safety profile of the lorlatinib was similar to that of reported into the previous studies of the lorlatinib. Grade 3 and grade 4 drug reactions which lead to the discontinuation of the lorlatinib or interruption of the lorlatinib dose, they are very less compared to the crizotinib. So these results support the use of the lorlatinib as an effective first-line therapy for the patients with the advanced ALK positive non-small cell lung malignancy. thank you, organizer, for giving me the opportunity, and thank you, audience and delegates, for patient hearing and patient attention. Thanks a lot.
Dr. Madhuri is here. Uh, uh, Thank you, Dr. Kaushal, for that wonderful discussion. And now I would like to invite our next chairperson. Again, next chairperson, both of them, they do not require any introduction in the field of oncology. First of all, I would like to invite Dr. Hemant Malhotra, sir. Dr. Hemant Malhotra, sir, is a